this is mostly about thoracic surgery, and there's quite a lot, so we'll see how we go for time. If you guys are starting to fall asleep, just let me know. I'm going to talk first about thoracic surgery in terms of lung, and then other times we do thoracic surgery, things like esophagectomy, mediastinal mass, and mediastinoscopy. So the start of this will be a bit of revision from the two previous talks. So those of you who missed Wednesday's talk, we'll have a brief recap, but I won't go into too much detail. But we have recorded that, and hopefully it will be up on the YouTube channel soon. So when we're talking about thoracic surgery, the things we need to consider are the type of surgery that the patient is having, the type of operation, what tests or preoperative assessments we're going to want to do, whether or not we need lung isolation, and if so, what technique we will use. Remember from our previous lecture, there's different ways we can isolate the lung, the most common way being a double lumen tube, and the other way we sometimes do is a bronchial blocker. Invasive monitoring, we need to consider what sort of invasive monitoring we need, and what analgesic plan we have, and all of this needs to be thought about before we even bring the patient into the anaesthetic bay. And then during the case, we need to consider our fluid management strategy and where the patient's going afterwards. And again, these are the things when we do our morning handover, these are the things we should be discussing. We had some good discussions this week in Rafidia about some of the big laparotomy cases. And if we want an ICU bed, we need to know before we start the case that we have an ICU bed available. And a lot of these thoracic cases need to go to ICU. So the next slide, we will start to talk about preoperative, what questions we ask the patient. For the most part, when we talk about thoracic surgery, there are three types of pathology. There is neoplastic, so cancer, infective surgeries, so things like tuberculosis, which is reasonably common in some countries for thoracic surgery, and end-stage emphysema is an uncommon, but sometimes still a reason we do thoracic surgery. So the operations in thoracic surgery we do by either thoracotomy or thoracoscopy. We can do a wedge resection, which is a fairly quick operation. We do a segmentectomy, which takes a bit longer, as I think I mentioned the other night. Taking out a lung segment involves taking the blood supply of that segment and also identifying that segment, and that all takes time. Lobectomy, which with a quick surgeon and a thoracotomy, a lobectomy would take an hour to an hour and a half. With a thoracoscopy, maybe 2 to 3 hours, depending on how quick they are. And a pneumonectomy, anterior mediastinal mass resection.
Eric,
Yep.
Eric, excuse me. I'm not able to type a chat, but I think Dr. Rawan has the microphone still on. Rawan, can you turn off your microphone? There's a TV in the background or something.
There has been a bit of noise in the lobby as well, so it's possible that.
No, it's not you. No, that's not you. And the only microphone that I see that's on is Rawan. So, Rawan, please, can you turn off your microphone, or you can turn her off?
Yeah.
By clicking at the.
I will do that. Yep.
It's making noise in the background. Thank you.
Okay. No worries. Okay.
All right.
So, just recapping, we've got
Hadil too, by the way. Well, Hadil is offline. Okay, never mind. Okay, good. I'll turn off my mic now.
Okay. So we have operations on the lung, which are either going to be open thoracotomy or thoracoscopy, anterior mediastinal mass resection, which is a topic hopefully I will have time to cover because it's very important and also common exam question in the Part 2 exam, and esophagectomy. So preoperative assessment for these patients is, as we talked about the other night, when we are assessing patients for lung resection, we always ask our routine questions about anesthesia, allergies, medications, when they've had surgery before and if there's been any problems, and their general medical history and so on, and then our specific questions and what ASA they are. And specific questions, remember we said the other night, cardiopulmonary reserve is very important, so knowing their functional capacity, their exercise tolerance, so that's something we need to get from the history, and I can't stress how important that is. And then once we've worked out their baseline health, we need to work out why they're having the surgery, what symptoms they're having. Sometimes people say, I had a chest x-ray, they found a lesion, but I have no symptoms. And then that's great, right? Because that means they're generally otherwise well. But sometimes with malignancy, particularly lung malignancies, they get paraneoplastic syndromes, and we need to know about that and know if they've been investigated for that. If it's infection, is it tuberculosis? Because these patients bleed a lot. Is it just a quick lung biopsy, like where they just take a quick incision, or are they taking out the whole mass? Or is it a hamartoma? So we see this commonly in children, the so-called CCAM, which is a congenital cystadenoma. I keep forgetting what this stands for, cystadenoma or something like that. It's essentially overgrowth of normal lung tissue, which is non-functioning. And it's not cancer, it's not really malignant, it's benign, but they can get very big and press on things and impair lung function. So in that way, they can cause problems. And they tend to take them out in the first year, often even the first 6 months of life, because it can affect alveolar development in the rest of the lung. And so we need to kind of have some idea of what is being taken out to plan a little bit about how difficult the operation is going to be. And I mentioned, obviously, exercise capacity. And then we have to think about what tests we want to do. We talked on Wednesday about the importance of spirometry. So if they're having a lung resection, then we need to know their predicted post-op FEV1 and possibly their DLCO. Gas on the room air, as I said the other night, is less commonly done, but it is something that we may do if we don't have the other tests. An ECG, look, anyone having thoracic surgery over the age of 60 should have an ECG, and I dare say if they're a smoker over the age of 50, they should have an ECG. You often regret not having an ECG preoperatively when you see ECG changes during the surgery. You never regret having one. So I think when in doubt, order an ECG. And these patients having major thoracic surgery must be seen preoperatively, as I was saying the other night, ideally 1 to 2 weeks preoperatively, if not before then. So we have time to get these tests and decide whether or not they're suitable for surgery. So if it's a big lung lesion, chest X-ray is useful for two things. One, to see where the lesion is, and two, when post-operatively, if they have a big lung resection, we have something to compare the chest X-ray to, and we can also use it to assess the severity of their pre-existing lung disease. And often the surgeons have done a CT scan, so it's useful to look for distorted anatomy, particularly if it's a mediastinal mass or a large bronchial tumour, to see whether we're going to have difficulty placing our endotracheal tumour. And then routine tests like full blood count UEC will be important in older patients. If there's significant blood loss expected or some concern about the history, like the patient has liver problems, liver disease, or is it alcoholic or something like that, then it's worth getting coagulation studies, but I wouldn't routinely do those. We should do a grip and hold for all but the most minor operations. If it's a large amount of lung tissue being resected, then we would look at some way of measuring their functional capacity, so the 6-minute walk test or a stair climbing test. And then echocardiogram in certain patients. So if they're having a pneumonectomy, might be useful. If there's a big mediastinal mass that on CT may be pressing on the ventricle, might be useful. Okay, echo for pneumonectomy is useful because when we take out the lung that we're removing, we also have to clamp the pulmonary artery on that side. And then what happens, we essentially divert the entire pulmonary blood flow, or the entire cardiac output through one pulmonary artery. So it's good to have an idea of this patient's right ventricular function, because if they have impaired right ventricular function, that can put them into cardiac failure. So it's important that we know what their right ventricle is like. So we talked a bit about on Wednesday night lung segments and percentage of lung removal, and remember we
Derek.
Yep.
Derek, I'm sorry, I can't write for some reason. I can't write a
So the group in the middle, 30 to 40% predicted post-op FEV1, are we consider extubation based on exercise tolerance, the DLCO, the VQ scan, and other associated comorbidities. So if the patients are otherwise reasonably well, then we would try and extubate. But if they had a lot of comorbidities, then we would probably leave them intubated. But look, for the most part, we were able to extubate these two groups of patients. It's the groups that are less than 30%. As I said on Wednesday night, if a predicted post-op FEV1 are less than 30%, in a study of 10 patients, 6 out of 10 died. And so extubating them in the operating room is generally not an option, and we have to look at stage weaning from mechanical ventilation. If you are going to extubate, a lot of people would say a thoracic epidural is an absolute must. The one group of patients I have anesthetized with predicted post-op FEV1 of less than 30% is the lung volume reduction surgery patients. These are the patients who have severe emphysema, who are having this very risky surgery called lung volume reduction, where they do it thoracoscopically. They snip out the diseased bits of lung, hopefully allowing the healthy lung to re-expand. And we would not proceed in those patients without an epidural because the analgesia has to be good. And we really don't want to leave them on a ventilator because their lungs are so bad that there's a good chance they'll never get off the ventilator. And I have to say most of them looked pretty horrible in recovery, but after a few hours, they either turn the corner and improve or they die. And I think of the 10 or so I did, about 8 out of 10 survived, which surprised me because I thought more of them would not survive. Lines. So the lines for most of these procedures are similar. For most ASA 3 to 5 undergoing thoracotomy, we would put in an arterial line for both hemodynamic monitoring and blood gases. Generally, if they're ASA 1 and 2 and they're just having a thoracoscopic procedure in the hands of a good surgeon, we don't always put an arterial line in. But if your surgeons are not doing it that frequently, and that case is going to take more than a couple of hours, I think or we don't do thoracic operations very often, I think an arterial line is very helpful for both guiding ventilation, monitoring blood pressure, and gases. Did someone just log in? Let me just mute. Okay. All right. Sorry, I'm just muting everyone. Central line we don't always need, but if they have significant comorbidities, if it's likely they're going to be ventilated afterwards, if they are likely to need inotropes, and often with a pneumonectomy we need to give some inotropes to keep our fluid down, then it may be useful. to use it for monitoring central venous pressure is controversial. I think those of you who have read anything about central venous pressure monitoring, one of the first things you'll read is that the monitoring the number is very, very inaccurate for a variety of reasons. We sometimes hear CVP being used as an index of right ventricular filling. That relies on the person having a normal right atrium, a normal tricuspid valve, and a normal right ventricle. And using it as an index of right ventricular filling doesn't always mean it correlates with left ventricular filling, because that means they need normal lungs and normal mitral valve. So all of those things, there's a lot of ifs in there. So to use it as a very crude index, fine, and we often look at the trend. So if we start with a CVP of 8 or whatever, and the patient's hypotensive, and we notice our CVP is 2, then sure, we might say, okay, maybe they need volume. But I use it more for drugs than for monitoring. But it can be useful. However, when you're doing a thoracotomy, it's in the lateral position with an open chest, and I don't think anyone really knows what a CVP number really means in that setting. But sometimes in the intensive care afterwards, it can be useful. But if you're doing a CVP in intensive care, the patient needs to be sat up to, say, 45 degrees, and the CVP transducer needs to be moved up to the right level, at the level of the neck, so that you actually are getting a CVP. And that's usually going to be done as a single reading every couple of hours. It's rarely going to be continuous. So just be very wary of actual numbers. But the trend can be useful. But as I said, I find it most useful for access and inotropes. Pulmonary artery catheter we wouldn't routinely use, but if they're going on bypass, or if they have severe pulmonary hypertension, there might be an indication for it. But if they're having severe pulmonary hypertension, then you have to question what is the operation and why are we doing it. Now, preoperative management of these patients includes an analgesic plan. Okay, this needs to be discussed with the patient and with the surgeon before we go into the operating room. And as some of you might have seen our Facebook discussion about epidurals in pediatrics, the same applies here. If your surgeon is not going to accept his patient having an epidural, then you need to have that discussion with him at the start of the operation and work out a good plan for analgesia. And likewise, if you're going to go to the trouble of putting an epidural in, you need your surgeon to understand how long you want that epidural to stay in for, and that you will be managing that epidural. And so the two common types of analgesic techniques we do, and this is for open thoracotomy, okay? This is the big incision. Thoracoscopic surgery, we don't generally do epidurals because they don't need it. The exception is the lung volume reduction patients, and I won't dwell on that. So the thoracic epidural is one technique, and the other technique is an extrapleural catheter plus or minus a patient-controlled analgesia machine with morphine or fentanyl. So my practice generally is to put the epidural in after the arterial line so I can monitor blood pressure, and then I put in a test dose 2% lignocaine with adrenaline, and then I load with 3 to 5 mils of 0.25% bupivacaine and fentanyl. And then so usually when I've given my test dose, I try and also test it with ice and see if I have something of a block before I put the patient to sleep. And then once they're asleep, I load them and watch the blood pressure. Now, if the patient's old and frail, I might reduce my load, and some people tend to not run the infusion intraoperatively if they're very old and frail. The reason for this is hypotension. So one of the problems, and I'll talk more about it in a minute, but one of the problems with pneumonectomy is these patients, we like to restrict their fluid intake because of the risk of pulmonary edema. And the problem with an epidural is it causes hypotension, particularly in older patients, and that means we give them more fluid, and that means theoretically that we could increase the risk of pulmonary edema, and so people are reluctant to give them too much epidural intraoperatively. my personal opinion is that if I'm putting someone through the risk of an epidural, I would like to use it intraoperatively. If they're old and frail, I would like to use the epidural to reduce the amount of isoflurane I'm giving them. And so I do tend to run it intraoperatively, but just at a very low dose, or I just intermittently top up. And I often will give some pressors for hypotension rather than fluid. But you'll probably come across different opinions about that. I tend not to use fentanyl during the surgery because if my epidural is not working, I want to know about it. And if you're running a fentanyl with your epidural local anesthetic, that can cloud the picture because fentanyl is so lipid soluble. It seems to work well whether you give it intravenously, epidurally, it will still work. So sometimes it's the fentanyl working, and those of you who've done labor epidurals might have seen this. You put an epidural in, you give some fentanyl with your local anesthetic, you think it's working, but then you get a call in an hour that the patient is in a lot of pain, and it's probably because the epidural wasn't working and it was just that fentanyl making them comfortable. So I might give fentanyl at the beginning, but then I tend not to continue it during the operation. That way, if the patient wakes up and they have a partial block, I can supplement it with parenteral opioids as well. So my induction technique, often I'll give midazolam while I'm putting the epidural in. I tend not to give midazolam to older patients, people over 70, just because it can cause more post-operative confusion. But often you'll give some sedation for the epidural. Then I induce with 2 to 3 mics per kilo of fentanyl. Remember, double lumen tubes are big and they're very stimulating going through the cords. And if you've got patients who have high blood pressure, and a lot of our patients do when they get older, I like to obtain that response, and I like to do it with fentanyl, and I induce with propofol or thiopentone or ketamine if they have pulmonary hypertension. So in pulmonary hypertensive patients, ketamine is a useful drug, and the reason is that if a patient has pulmonary hypertension, that means they have high strain on their right ventricle. Now, if you give a big dose of propofol, you drop their systemic vascular resistance, and what that can do is causes the right ventricle, which is already working quite hard and has a high pressure. The right ventricular pressure can rise above the left ventricular pressure momentarily, which causes the intraventricular septum to also shift to the left, and it also decreases blood pressure and decreases perfusion to the coronary arteries, which are supplying that thickened right ventricle, which is doing more work than it should be doing. And what can happen then is you get right ventricular ischemia with prolonged hypotension, in systemic hypotension in the setting of pulmonary hypertension. And then the right ventricle starts to struggle because it's not getting the blood flow that it needs, and that causes reduced filling to the left ventricle, further hypotension, and it just becomes a cycle and a spiral, and these patients can run into serious trouble. So if they've got pulmonary hypotension, I tend to use midazolam, fentanyl, and ketamine to maintain their systemic blood pressure rather than propofol or thiopentone. And then whatever relaxant you prefer to use, it doesn't matter. Intubation, usually with a double lumen tube of the correct size. And then we check our position as we talked about on last week. And it's better to put it a bit too far in, because once we put them lateral, it often pops out a little bit. We put the patient in the lateral position. We're talking about thoracotomy and lung resection. We check our pressure areas and padding. We check our eyes. We make sure the neck is not floating. We check our axilla is clear and the roll is not compressing the brachial plexus. We check the tube position. And then if the surgeon is fast, often I'll go on one lung ventilation at this time. If it's a pediatric surgeon or a general surgeon, they're not going to be that fast. I would go into one lung ventilation when they tell me or when they're getting close to getting into the chest. So I maintain, as I mentioned, with my epidural for pain relief, so I don't repeat my fentanyl. I use volatile most commonly, although there's no reason you can't run an intravenous anaesthetic with propofol. I'm prepared for dropping blood pressure with my epidural load. And as I mentioned, some people don't run it throughout the surgery. And I tend to treat it with vasopressors. Which vasopressor? It doesn't matter. Phenylephrine, ephedrine, noradrenaline, whichever one you have. Fluid management is a big deal in thoracic surgery, and we tend to run a really dry fluid strategy, so what's called a restrictive fluid management strategy. Dr. Hafez can probably comment on this, but anesthesia seems to go through phases about fluid management. When I started training, there was a lot made about giving too much fluid in bowel surgery, for example, because it seemed that the bowel became more edematous and affected the anastomoses, and it was suggested we reduce our fluids in bowel surgery. Thoracic surgery for many years now has run a restrictive fluid strategy, and I'll talk about why that is. Plastic surgery for free flaps and big grafts also we get a lot of fluid because those patients are often very hypotensive because the surgeons have topicalized so well, but we still have to keep them asleep. And so they get hypotensive, which isn't good for the graft, so we give them a ton of fluid because the surgeons don't like us giving vasopressors. So there's a lot of stuff made about fluid, and I think more and more people are moving now towards a restrictive strategy for a lot of operations. But bear in mind that hypotension is not good either, and a lot of these patients have ischemic heart disease. They may also have some renal impairment, and if you keep them too dry, you can make those things worse. So these are often sort of delicately balanced operations in the sicker patients. And we all have some bad outcomes sometimes, and we all wonder if our fluid strategy could have been better. But we run them on a restrictive fluid strategy because we run them on a restrictive fluid strategy because we worry about pulmonary edema. What I was taught is these patients get 1 to 2 litres of crystalloid maximum, then start vasopressors. So 1 to 2 litres equates to about 20 to 30 mils per kilo. These patients are going to be around 70 to 80 kilograms. Once you've given your initial fluid load, start vasopressors. So in a lot of surgeries, we have our drip constantly running, and we're always giving a bit of maintenance fluid. The practice generally in thoracic surgery is give your drugs, flush them in, turn the drip off. Don't leave the drip running, because before you know it, you'll have put in 1 litre or 2 litres, and then you've used your entire quota for the case. So they tend to run very restrictive fluid strategies and replace bleeding with fluid and blood. So Ruba's just asked a question, how 1 to 2 litres over what time frame? So as long as, for me, I basically, as I said, I give my fluid for my induction drugs, and then I turn my fluid off. And I don't turn the fluid on unless I have hypotension. If I'm using an epidural, I might give a fluid bolus. Or if I'm flushing drugs in, and when I've reached that 1.5 litres, then I start to use phenylephrine or metaraminol, or if it's going to be a really long case and I have a central line, I may start noradrenaline. So there's no specific time frame. It's just when you've used up that amount. So when you go, oh, that's my second bag, as I'm hanging my third bag, I'm trying to use vasopressors. For the big cases, they should have a urinary catheter in, and they should have ideally an hourly urinary monitoring bag on that catheter, and we can look at their urine output. I'll talk, I think, on the subsequent slides about urine output and whether it's important or not. Personally, I like urine output. So they don't all need urinary catheters. I think for pneumonectomy, definitely. For lobectomy, they shouldn't need it. The reasons you might want one is if the patient has renal impairment, if the patient is compromised, they have a lot of comorbidities. If the surgeon is very slow, if they're an American surgeon that is on a mission in, say, Palestine, as we saw this week, they're often very slow because it's not a familiar environment for them. They've often got staff assisting them they're not used to. They get very worried about a lot of differences, and they'll often be very slow. So I think we could justify on these guys coming for surgical missions to put more monitoring on our patients, because we know the cases are going to take longer. But if it's a local surgeon that you know is quick, then I think it's, it might be reasonable to not put a catheter in everyone, because putting catheter in can have a few risks too, right? We can introduce infection and those sort of things. So if the patient is going to intensive care afterwards, or if you're not going to extubate or whatever, then sure, put a catheter in. It's very useful. And again, it's one of those things that if you didn't do it and the case blows out to 5 hours, and yeah, you regret it, and it's really not easy to get under the drapes and do it. So it's better to do it at the start if you have any doubts. Was that the question, Rowan, that you were going to ask about catheters? That's what I assumed the question was. Okay, so
hold on. She may. I asked her to turn on her mic and ask the question. Roland, she's a consultant anesthetist, and so I value her question.
Yeah.
More than Roland. You.
She's still muted. I've unmuted her from my end. Okay.
I'll give her a couple more seconds, and if she doesn't...
She said it was okay on her.
Okay, that's fine. Good.
Okay.
I'll turn off my mic again now.
Okay, so restrictive fluid management, and more so when it's pneumonectomy. 1 to 2 liters of crystalloid, and then I start the vasopressors. So we're talking over the duration of the case, I guess. Usually you'll find, depending on how good you've been at turning your taps off, you'll find that you'll get to 1 to 2 liters maybe an hour and a half in, especially if you're using an epidural, because you're probably going to give a bit of fluid. And then when they bleed, then you've obviously got to replace that. So that gives you a little bit more room to give some fluid, and you're going to replace it with fluid, and then if necessary, blood, along with the same guidelines we usually use. So when you're getting 40, 50 mils per kilo of crystalloid replacing blood, or your hemoglobin's dropping, then you're going to use blood. For the most part, in a good surgeon's hands, neoplastic lung resections do not bleed that much. So a pneumonectomy, a lobectomy, if the surgeon is getting his planes right and it's not a particularly aggressive cancer, they don't tend to have a lot of bleeding, and I don't think I've really transfused those. The exception is mesothelioma. Now, mesothelioma resection is probably not done in Palestine. It's not done really much in Australia. I've never seen it in Australia. They did do them in Canada. The reason it's not done that much is it's doesn't have great outcomes. It's a very aggressive surgery. They don't just take the lung; they have to take the pleura as well, because as you remember, mesothelioma is like a pleural sort of tumor. And as they strip the pleura off the chest wall, these patients bleed a lot, and they're long cases. They're interesting cases, but they need a lot of fluid. And I think all my fluid restriction guidelines go out the window in these patients. There's this concept in lung resection surgery, particularly in the mesothelioma cases, called giving vasopressors to make room to give more fluid. So we want to run a restrictive fluid strategy. We try not to give too much fluid, but if the patient's bleeding, we have to at some point replace volume, replace blood, and so on. But all this extra volume we give, we always worry about what effect it's going to have on the pulmonary vessels, because with the pneumonectomy, we halve our pulmonary vascular bed, so we increase the risk of pulmonary edema. So they talk about giving inotropes to reduce the amount of fluid and keep the blood pressure up, and also sometimes giving some Lasix. And I worked with some people in Canada that like to give a little Lasix to create a bit of room, as it were, get rid of a bit of water so we can replace it with blood. So that's really only in the big bleeding cases like mesothelioma. A normal pneumonectomy should not bleed that much. The other cases that bleed a lot are tuberculosis cases. And if you work in Africa and countries where there's still a fair bit of tuberculosis, you see when they strip the pleura, they do decortications to try and re-expand the lung and remove the inflammatory tissue. They bleed a lot as well. So the reason why we think there's an increased risk of pulmonary edema, and again, a lot of this is theoretical. I don't know how much of this is fact, but as you know, we always get blamed for things. And when there's a pneumonectomy or lung resection and the patient gets pulmonary edema afterwards, we often get blamed. And I'll explain a little bit on subsequent slides why we get blamed, and sometimes it is our fault, but it's often not due to fluid. But the theory is the lung tissue becomes traumatized because obviously the surgeon's operating on it, they're retracting it, they're pulling on it. And when we traumatize tissue, we traumatize blood vessels, the capillary membranes become leaky, and that tissue is then going to get swollen and edematous, just like it happens when you bruise your arm or your leg, it gets edematous. So that happens to the lung, and that's bad. And then if we give too much fluid, the theory is, well, these lungs are already leaky. Now we're giving more, there's more fluid floating around, so we contribute to the pulmonary edema that way. And also, as I mentioned, if it's pneumonectomy surgery, we've significantly reduced our pulmonary vascular bed, yet we've still got 5 liters of blood going around, so the pressure is going to be higher. So then that also increases the risk. So for those theoretical, or they're not theoretical, they're pathological sequelae of lung resection, we tend to run our patients dry. Now, pneumonectomy, as I mentioned, is the one we were particularly scared of with fluid. We run them very dry, and we talked about the pulmonary hydrostatic pressure. The other thing I didn't mention on the previous slide is they lose half their lymphatic drainage. So, as you know, when you get edema, some of it's going to drain back into the vein, but most of it drains through the lymphatic system, and we've halved our lymphatic drainage with pneumonectomy. And so this fluid hangs around a lot more in the interstitium, and some of it can creep into the alveoli, causing pulmonary edema. Now, 20 mils per kilo positive balance at the end of a case is considered maximum for a pneumonectomy. So when I say positive balance, that means that you might be thinking, well, what if they bleed a lot? So as long as we replace what they lose and don't exceed 20 mils per kilo, then we're not considered to be giving them too much fluid. I used to hang my head in shame when I turned up to the ICU in Toronto and told them how much fluid I gave if I'd exceeded 20 mils per kilo. If it's like 40 mils per kilo, they're all silently judging me. And you want to say you weren't there, you don't know what it was like, but some units are very strict about this. And at the end of the day, you've got to do what you have to do, right? If you felt the patient was very hypotensive, maybe you had to give more fluid, that's acceptable. This is just a guideline. It's not absolute, but it's just a guideline. And it actually is all theoretical. It comes from an article that Professor Peter Slinger wrote in about 1990 or something like that, or 1994, where he looked at a whole bunch of physiological components to come up with this number. There's been no studies on this and what happens when you give more or less, but it's just a guideline. And then after they go to ICU, they try and limit the amount of fluid. What often happens, especially if they have an epidural, is that, and I've seen this, we give them Pressors intra-op, we run them dry, they have no urine output, they go to recovery or ICU. Recovery says, oh, no urine output. They give them like 500 mils to a litre of fluid, which is sort of negating everything that we've just tried to do. And they're fine. So that's why I think that a lot of the literature and people get very caught up in this. But often they will get a lot of fluid later on anyway. But one of the problems with epidurals, and one of the reasons the hospital I work at in Australia doesn't like them for lung resection, is that because they're often hypotensive on the ward, either they get given a lot of fluid on the ward, and the feeling of the surgeon is that they get too much fluid to bring their blood pressure up, or people switch the epidural off because they think, well, they're hypotensive. Then the patients end up getting a lot of pain, and then they get atelectasis and pneumonia, and it's just messy. But I think all of those things are related to not having an adequately educated nursing staff. If the nursing staff are doing a lot of thoracic surgery, as we did in Toronto, they knew how to manage the epidurals. They didn't just turn them off. They'd try things like turning them down and other strategies, and persevere with them. So a lot of it, these techniques need to fit the hospital you work in. If the people are not used to using epidurals, then it may not be the best thing for the unit, because people panic and they just pull them out after a day because they turn it off and the patient has pain. Then they say, oh, the epidural isn't working, so I pulled it out. So these are all unit dependent, and I'll talk more about that when I talk about analgesia. So back to pneumonectomy, because we have this restrictive fluid strategy, we often will start vasopressors early intraoperatively to reduce the amount of fluid and try and keep within those guidelines. So I mentioned that we worry about pulmonary edema. Why worry about pulmonary edema? Well, if you have two lungs, pulmonary edema is something that we've often seen and we've often treated, and often these patients do fine. Unfortunately, with pneumonectomy, they don't do so well. So one study looked at 806 pneumonectomies, 21 cases of pulmonary edema, 16 were right pneumonectomy, 15 on left pneumonectomy, which kind of makes sense, because if you're having your right lung out, you're getting 55% of your vascular bed removed rather than 45%. So not very good. All of them died. That's pretty shocking, isn't it? I mean, 100% mortality if you get pulmonary edema. So that might help you understand why, even though a lot of this stuff is not based on solid evidence, you don't want to be the anaesthetist that gets blamed for pulmonary edema in a patient, because if they get it, they die. This study was before ECMO. So with ECMO, some of these patients can survive, but it's not obviously a very good complication to get. When they looked at the cases of pulmonary edema versus the controls, there was actually no significant difference in the fluid balance. There was no significant difference in the amount of fluid they got, and the mean pulmonary artery pressures initially were 10 and finally at the end of the operation were 13, meaning the pulmonary artery occlusion pressure, or pulmonary artery wedge pressure, which is a measure of your left ventricular filling, went up a little bit, but it was not thought to be significant, statistically significant. So that's the article. What does that mean? I mean, what that says to me is, okay, it wasn't really the anaesthetist's fault, because there didn't seem to be a big difference between the case and the controls in how much fluid they got. We know if they get pulmonary edema, it's a disaster, but whether it's because of our fluid is a little less clear. But the dogma in thoracic world, the teaching is we run restrictive fluid strategies, and it makes sense. It's just that we I guess it's a hard thing to study, and we're not going to randomize people because of the high mortality if they do get pulmonary edema. There's also a lot of stuff out there about fluid management. There's some newer articles. There's a good review at the bottom of this slide by Chappell in Anesthesiology in 2008 on fluid management. And in that article, he says that there is no third space. So we talk a lot about third space losses, patients with bowel obstructions and so on. But he says that we often for years we've been overestimating third space losses, and we give too much fluid. We overestimate fasting deficits because we say, oh, well, they've been fasting since midnight. It's now 8 o'clock in the morning. They're probably dry. Let's give them a liter at the start of the case. And he's saying that's not true. First of all, most of us don't eat between midnight and 8 a.m. anyway, unless it's Ramadan. And so we're probably not that dry. And their blood volume doesn't actually change when they're fasting for the most part, unless it's prolonged fasting. Insensible losses we overestimate, and he's saying that 0.5 to 1 mil per kilogram per hour is probably all we need to account for. And hypotension is worse than vasopressors. So essentially what that article would suggest is, rather than giving lots of fluid, let's just be more rational with our fluid and treat hypertension with vasopressors. Don't let them get low, but don't give them too much fluid. I will point out this is for adults. For pediatrics, I think we still tend to estimate our insensible losses at higher than this, but I also think children have better hearts and better kidneys than patients having lung cancer surgery. But Chappell was talking generally, and I think this applies equally to bowel surgery. And certainly since doing thoracics and reading this article, I try and be a lot more stingy with fluid. And in children too, I'm quite stingy with fluid, especially in babies, because I think I can always give more fluid, but once you give the fluid, it's very hard to take it back. But there's a lot of there's probably a lot of differences of opinion about this. So just more on the pulmonary edema. So as I said, in that one study, it looked like fluid didn't seem to make a big difference, but the probable causes of pulmonary edema in the healthy lung, right, the lung that they haven't touched and operated on, because remember we said, oh, well, they can get pulmonary edema because the surgeons traumatized the tissue. This is the other lung now because they've taken that lung out, so there shouldn't be trauma, right? But there can be trauma from our ventilation. And remember I talked about one lung ventilation and what these things called barotrauma and volutrauma and atelectrode trauma, and I'll show you a slide about that coming up. But if we're to aggressively ventilate our patients, we certainly can cause trauma, and that causes endothelial injury, and then it's just like the damaged lung tissue that the surgeon operated on. We have the capillary hydrostatic pressure, which increases with pneumonectomy, and indeed any major lung resection. They get cytokines released, and that's to do with the ventilation, and also to do with this inflammation, maybe from the surgery on the other side. Those cytokines go into the blood and can cause local inflammation in the lung. Fluid overload is considered to be a probable cause. Lung hyperinflation, though, is the big cause. Remember I talked about the old studies where we used to give 15 mils or 10 mils per kilo to patients' lungs. We no longer do that because we realize that this is a major cause of lung injury. Other postulated causes, suggested causes, right ventricular dysfunction. Obviously, if they have a dodgy is an Australian word for impaired right ventricle to begin with, then we go and stress that right ventricle by reducing the pulmonary vascular bed and increasing pulmonary vascular resistance. That can contribute to pulmonary edema. The lymphatic drainage of the lung is halved, as we said, and oxygen toxicity. And theoretically, we get oxygen-free radicals if we give too much oxygen. But again, that's theoretical. So the reason why hyperinflation and ventilation can cause damage is, well, not so much the reason, but the evidence comes from a few studies that have been done. This was an interesting study done in 2002 where they had ARDS, which stands for acute respiratory distress syndrome. they did 583 lobectomies, and they had a 3% rate of ARDS, 17 out of 583. Of those 17, 9 had CT scans. And you can see this CT scan here. This is the lung with ARDS. This doesn't look too healthy. This is the other lung. Which is the lung that was operated on? This one. You can see the chest drains there. So that means this was our lung. This was the lung that we as the anaesthetists were ventilating. And indeed, in that 9 out of 17 cases, 8 out of 9 patients with ARDS, it was worse in the non-operated lung. That is the lung that was ventilated during the operation. That says to me that we have to be careful. Most of the time in anesthesia, it doesn't really matter what we do, because anesthesia is very safe for the most part these days. Our drugs are very good. But I think this study shows we can actually do harm on one lung ventilation if we're not careful. So that's why we have these rules that we talked about last week. You want to mimic normal spontaneous ventilation. We keep our FiO2 as low as is safe. Keep our tidal volumes of 4 to 6 mils per kilo. And this is the same as 2 lungs. We do not increase it, okay? We do frequent recruitment maneuvers. We not too worried if the tidal volumes vary. That's normally physiologically what happens. And we keep our PEEP to maintain functional residual capacity. So this slide just shows what happens if you put someone on conventional ventilation, high tidal volume ventilation. We're talking about a 70-kilogram patient. We blow in 800 mils of volume, and then we don't put PEEP on, and we let the lung completely collapse in between breaths. Someone at work asked me the other day here why I like PEEP. This is why, okay? I was trying to explain that if we don't put PEEP on, so we blow in this big breath, we might stretch the lung even if we give too much volume. And then we exhale and the lung completely collapses, and that causes gradual release of cytokines and trauma to the alveolus. And it all contributes over 2, 3, 4 hour case to potential damage. Yes, if it's a 30-minute case, 40-minute case, it probably isn't going to cause too much harm. But I guess my thinking is, if we know something for a prolonged period is better for the patient, then why not do it for a shorter period? If ICU ventilation strategies are better for the patient for 24 hours or 48 hours in ICU, why not do it for 2 or 3 hours in the operating room? So that's my practice. And this image just shows that if you give PEEP, you keep a nice FRC. The lung doesn't collapse; it just goes down, but it stays open. And then you don't have to blast it with the next breath to re-expand it. You just pop a bit more air in with less pressure, and it keeps it nice and open. So I think that's a nice image. Rwand has a question. Put your microphone on.
Hello?
Yes. Go ahead.
No, I just wanted to ask about that chest the CT that you showed us. How it is by
one side.
ARDS is. Yeah, it's one side. That's what I wanted to ask. It is ARDS, but it's only one side, not bilateral.
Yeah, well, that's
one of the.
Yeah, that's what's so extraordinary. I think this study surprised a lot of people because it showed that that left lung was not. The left lung was the one I guess we were ventilating. The anaesthetist was ventilating in that case, and the other lung that had the surgery has been protected by not being ventilated for the 3 or 4 hours. So I think the thinking is, well, what went wrong? Why does only one lung have such a bad injury? And it's because of the ventilation strategy used in that case. They probably overventilated that lung, and the patient perhaps was getting 10, 12, 15 mils per kilo. I don't know. But they think it's probably due to too much ventilation, stretching of the alveoli, cytokine release, which the operative lung was protected from because we weren't ventilating it.
And another question, what PEEP do you like to give during?
Look, I start with 5 routinely, unless they have severe emphysema, in which case they often have some auto PEEP, in which case I'll often turn the PEEP off. Ideally, with thoracic surgery, you want to have a good spirometry measuring device on your machine, and the ones we had in Toronto where I did my fellowship could measure PEEP. That was the GE or the Datex machine. It could actually measure PEEP, and so it would tell me that the patient had 3 or 4 of PEEP, and then I wouldn't put any more on. But usually I start with 5, and then I increase if needed. So if I find that with 5 of PEEP, I'm struggling on one lung, they're desaturating a lot, and I'm having to recruit them often, then I'll often go up to 6 or 7. And when I talk to my intensive care colleagues about PEEP, certainly in ARDS patients and sick lungs, they tell me that they have no hesitation turning the PEEP up to 10, 12 in the intensive care setting, which makes me think if we have to give 7 or 8 or 9 in the operating room because the patient has pulmonary fibrosis or not normal lungs, then it's okay. And remember, I think the old thinking that too much PEEP on the lung, we're ventilating on one lung, diverts all the blood to the operative lung and causes more desaturation. I think that thinking is no longer valid, because we know that if they need more PEEP and we give more PEEP, we bring the ventilated lung closer to functional residual capacity, and that should help our blood flow, not push it away.
Okay, thank you very much.
No worries. Okay, so thank you for that question. So protective ventilation strategies we talked about, and post-operative analgesia. Now, this is an important topic because these can be very, very painful operations, and it's always a balance between comfort for the patient and respiratory depression. If the patient has a lot of pain, they hyperventilate, they get atelectasis, and they are high risk for pneumonia. Likewise, if we're giving morphine or fentanyl and we give too much, then they hyperventilate. So it's a balance between getting that dose right. The gold standard in the literature is considered to be the thoracic epidural. In studies, that's shown to have the highest patient satisfaction. And there's a question. Hang on, I think Mustafa has a question. Mustafa, do you want to turn on your microphone? Go ahead, Mustafa. I'm not hearing anything, but you have typed a question asking about the hazards of high PEEP for a long time. Sorry, I cannot hear you, Mustafa. Are you okay? So yeah, look, Mustafa's asked the question about the hazards of high PEEP for a long time. To be honest, I don't know that much about the hazards of high PEEP for a long time because I'm not really an intensive care person. I mean, I think when patients get very stiff lungs, as they do with ARDS and pulmonary fibrosis, they often need high PEEP when they're on a ventilator. I think the bigger hazard in these patients is hypoxia and CO2 clearance. I mean, I think high PEEP can certainly be a problem if the patient has concomitant heart disease and heart failure in some people because it can increase afterload, reduce preload. But I think my approach is if they need PEEP, I give PEEP, and I do it as a sort of a trial and error, and I increase it up to the amount they need. And I think it's similar in the intensive care setting. If you're struggling to get reasonable tidal volumes and ventilate off CO2, then you may need to push up the PEEP and then wean it back when they no longer need it. Barotrauma with PEEP. I think you're more likely going to get, so Mustafa's asking about barotrauma with high PEEP. I think you're more likely going to get barotrauma if you have a high inspiratory pressure and high peak pressures. PEEP is a gradual increase on the end expiratory pressure. You just have to be aware that as you give more PEEP, you're going to need a higher inspiratory pressure to get a tidal volume. But we talk about low volumes, high frequency in these patients with really sick lungs, and we let their CO2 rise if we have to. So I think you're more likely to get barotrauma if you're pushing big inspiratory pressures and not giving PEEP than if you give more PEEP to try and keep the lungs open to hopefully reduce how much inspiratory pressure you need to give them. But like I said, I'm not an expert on the prolonged use of PEEP in ICU. But if anyone else wants to shed any light, feel free. Number one has another question. Go ahead, Rwand. Turn on your microphone.
Hello?
Yes.
Actually, it's not a question. I attended a lecture lately, last week, on the same subject, and they talked about the benefit of the inhalational anesthesia in the protection of the lungs during lung surgery and thoracic surgery and lung. They talked about the sevoflurane. They said that it's very good to give the patient inhalational anesthesia, inhalational gases, and about sevoflurane, that even before they transplant the lungs from the donor, they showed us a slide that they put them on sevoflurane for 3-4 hours before and ventilate the both lungs.
Oh, really?
Wow. Yeah. And it was for me a big surprise. So I want to ask you if you heard about something about that, or you have.
Yeah, I had not. Was that in Canada, those guys, or were they in Europe?
No, it was in the ASA last week in the United States.
Oh, the ASA, yeah.
I don't remember the name of the anesthesiologist who talked about that in the lecture.
Okay, it wasn't from Toronto, the Peter Slinger.
I'm not sure. I'm sorry.
Okay, no, that's okay. That's okay. Well, when I was in Toronto, they were starting to do the ex vivo lung perfusion. They'd been doing it for about a year. So what that was is similar like to what you described. They were taking the lungs and ventilating them and perfusing them for 3 or 4 hours, or mainly to try and get rid of any edema and get them in a little better condition, and they called that ex vivo perfusion. But they weren't at that point running sevoflurane in Canada, so I don't know if they're doing it different in the US. But I think one thing we know about volatile anesthesia in the heart is ischemic preconditioning. So I wonder whether it's related also. It's related to that with the lungs, whether it somehow helps with ischemic preconditioning of the lungs, because obviously when you're doing a lung transplant, you are going to have an ischemic period, and so when they take them off the ex vivo circuit before they implant them in the patient, there's often going to be a period of a few hours of ischemia. So I wonder whether it's due to ischemic preconditioning that it's beneficial. I'm not sure if they talked about that.
I think that it is about protective strategies. He talked about the fluids and everything, about ventilation, about the diuretics, the vasopressors, everything. And at the end, he talked about this, about the sevoflurane. That is very good as one of the protective strategies to ventilate the patient on sevoflurane during the operation.
Right. Okay.
That's what I understood.
Yeah.
That's what I understood.
Okay, well, that's interesting. I mean, I was not aware of that, but it kind of makes you feel better about using gas then over propofol. I mean, we use isoflurane, sevoflurane. Maybe that's what we should continue to do. But yeah, I was not aware of that. So
and
thank
about
you.
The PEEP, thank you. About the PEEP, what Dr. Mustafa asked, I did fellowship in intensive care. We used to give in severe ARDS patients. We even sometimes we give PEEP of. You will be surprised, of 15 sometimes.
Yep.
14.
Yep.
For very few patients, not, but we did it. We gave just to make the oxygenation better
Yep.
with these patients.
And any issues with
we use it.
Any issues with pneumothorax or barotrauma?
We didn't see, but pneumothorax, no. But they were not afraid. Sometimes it's not few patients only with severe ARDS that we couldn't oxygenate them. We gave even 13, 14, and once I saw 15 people with one patient. I didn't see barotrauma or pneumothorax with these patients, but it happened. Maybe with other patients,
and I think
not tolerate this high PEEP.
Yeah, I think that's fair, and I think it's a good question Mustafa has asked. And I guess the approach is probably these patients are so sick that you're just doing what you can do to get oxygen in, and if you have the complication, unfortunately, you have the complication. But if you're getting to that point, you're obviously starting to get desperate.
You haven't anything to lose, so you try everything.
I mean, in the operating room for one lung ventilation, I think I rarely go above I've gone above 7 or 8. The other, I mean, I guess you reach a law of diminishing returns that you can push up your PEEP, but then if your tidal volumes are starting to fall and your oxygenation or your carbon dioxide clearance isn't getting any better, then I just back off again, because a lot of it is trial and error, because you're looking for that magic functional residual capacity volume in each patient to get improve their blood flow. And I guess we have the luxury in the operating room of being there all the time and being able to monitor it. In the intensive care, they're not monitored as closely. So
yeah, exactly.
Yeah. Okay. Thank you.
Thank you.
We'll continue. So regarding analgesia, so as I said, thoracic epidural is considered the gold standard, but there is an extrapleural catheter, which is a good alternative, and it's been shown to be almost as good in studies. Extrapleural catheter is basically a catheter that can either be inserted by the surgeon. The hospital I worked in, mostly it was done by the surgeon. He does it at the end of the operation, and it sits just outside the pleura and provides local anesthetic in that potential space outside the pleura, and it can be very effective, and it has some good advantages in that it doesn't cause hypotension because it's not an epidural. It's just blocking the paravertebral nerves. It's inserted under direct vision, so theoretically you would expect less complications. If the patient's coagulation profile is a bit dubious, a bit doubtful, there's no risk of an epidural hematoma if bad coagulation, you wouldn't put an epidural in, so you could use extrapleural catheter in these patients. The disadvantages is that the pleura must be intact, so if it's a decortication where it's all scarred and messed up, it can't be used. If it's an extrapleural pneumonectomy, there is no pleura, so you can't do it. it requires your surgeon to be motivated and believe in the technique. So one of the things I found is the surgeon I've worked with in Australia, he really prefers that. As I mentioned, they don't like epidurals because of the hypotension and the fluid issues. So he really liked this technique and he got good at doing it, and his patients are generally pretty comfortable. And I think from memory, they say it's about 90% as good in the studies in terms of patient satisfaction. The downside to it also is that it's done at the end of the case. So if you have a patient you want to run on a local anesthetic based anesthesia technique because you don't want to give them too much volatile, you can't do that with an extra pleural catheter. So that's another disadvantage. But it's good because it's only unilateral. It's only the side that you're operating on. So they definitely have advantages. And we usually run them with opioid, like give the patient a PCA as well. So the paravertebral, this is just a shot of the anatomy. So the spinal cord here, the spinal nerve roots, anterior posterior division, and the paravertebral comes out just laterally to that. So the paravertebral catheter, if we can insert them as anaesthetist too, and your technique is instead of going midline, you go paravertebral, still using a TUI needle, and you thread the catheter in the paravertebral space. You do get a loss of resistance similar to what you get with a epidural. I've never done one, but I've read about it. I have done paravertebral blocks once, but with a paravertebral block, you've got to do multiple levels to cover the incision above and below, probably 3 or 4 levels at least above and below. And obviously, you're only going to get 6 to 8 hours, depending on what you put in your local anesthetic. Additionally, you could also give intercostal blocks. So this picture just shows the paravertebral space that you're aiming for. So normally you'd go midline, you're going sort of here if you're going paramedian, so you're going even more lateral to get the paravertebral space. If you're doing it, doing a block, so essentially you hit the rib and you go, you find the transverse process and you go somewhere between there and the rib. Like I said, I'm not that familiar with it because I've only done it once. Intercostal blocks, a surgeon can do, particularly if it's thoracoscopic surgery, the surgeon can put them in under direct vision, and they can put them in under direct vision with a thoracotomy too. But again, they're only going to last 6 to 8 hours. For a thoracoscopic case, that's often good enough, but for a thoracotomy, they're going to have a lot of pain, and so they need something longer lasting. But sometimes you can't do an epidural or the patient doesn't want one, and it may not be appropriate for an extra pleural catheter or the surgeon doesn't do them. And then you're left with intercostal blocks or paravertebral blocks. The intercostal blocks, definitely I would recommend using adrenaline because there's a very high blood flow and the local anesthetic gets absorbed very fast from the intercostal area. So this statement just to say that these blocks are effective. It's just that they're short-acting, but they have been shown to increase post-operative blood gases and pulmonary function tests and shorten hospital stay. So they're not useless. If you can't do the others, then this is a very good plan as well. And then we use multimodal analgesia, so we give them all paracetamol and non-steroidals, anesthesia contraindication. So those are the main analgesic techniques. And this graph just shows patients who had post-thoracotomy pain and at 2 months and 6 months. And you can see how high this is. 90% of patients who had a PCA were still complaining of pain at 2 months down the track. And I remember reading that thoracotomy pain, about 50% of these patients will develop some sort of chronic pain. The definition of chronic pain is pain that lasts more than 3 months. So it's a huge problem, and it's probably an underreported problem. And we often don't see these patients again, and our surgeon may not tell us, but it is a problem. If you ask the surgeons, a lot of them will admit, yes, a lot of these patients still have pain when they come back and see me. So this graph, for those of you that are advocates of epidurals, this graph is great, is a great weapon. I can't remember where I got this from, and so I can't I think I might have even pinched this from someone else's talk, so I probably don't even have the reference. But so I don't know what quality of study this was. But what this essentially shows is that in the orange, you have the patients who we gave the epidural to before the incision. In the blue, they got it at the end of the case. And the green, they got a PCA. And what it shows is that both at 2 months and 6 months, there is less pain in the patients who got an epidural than who got a PCA. And it's statistically significant. That's what the star means. There wasn't a statistical significant difference between the pre and post epidural, but there was definitely statistical significance between the epidural and the PCA. I always try and give it at the start of the case because, as I mentioned, I like to run it during the operation. And for those of you who believe in preemptive analgesia, I know that there's not a lot of scientific evidence that preemptive analgesia works, but it makes sense that if they've got some pain relief on board before the surgeon makes the cut, then hopefully they have less pain afterwards. And I'd like one day someone to show me they have less chronic pain. No one's been able to do that yet, but I'm going to still keep trying to do my epidurals before the surgeon cuts. And this post-operative care in the epidural group, in the thoracic surgery group, generally we nurse them in the semi-upright position. We're careful about fluid management post-operatively, as I mentioned. Very important for the pain service to visit regularly. APS stands for acute pain service. Twice a day if they have an epidural, I think that's a must. In the morning, maybe before we go to theatre, just to see how their night was and make any adjustment. Go back in the afternoon because we want to know how our adjustment went. We want to show the patient we're following up this epidural. We want to show the surgeon we're following up this epidural, and we want the nurses to know that we're available for them if they're having problems with this, because a lot of our nurses don't look after epidurals a lot, and often they don't really understand the management strategies. And that, when we see a patient with an epidural, just this is slightly off topic, but it's important to ask about, first of all, their pain on breathing and coughing, and making sure that they can do those two things. And it's important to assess their arm and leg strength, depending on whether it's a thoracic or lumbar epidural, because we need to know if the epidural is too strong, if they've got any weakness, we need to turn it down. Or if there's been a complication, potentially, we need to know they can still move their arms and legs with power. And particularly if it's a lumbar epidural, bladder function, they probably really need to have a catheter in while the epidural is in if it's a lumbar epidural, so they don't get urinary retention. So I usually like to see the block, the actual block height. So I usually take ice or take a pin, or you can do it with an alcohol wipe running down their body and work out where your block is. And I usually document, okay, the block is T4 to T8 or something like that, because if they say, doctor, I've got pain, and you don't know if it's because your epidural is not working or you just haven't got the right block. So if you can at least map out the block, if they've had a thoracotomy, the incision is probably T5. If you have a block T7 to T10, maybe you can push that block height up by giving a bolus of local anesthetic. So that's why it's important to map out the block, and that should be done every single day. And if the patient says he or she can't move their legs, or they have arm weakness, you might need to turn the epidural off for a couple of hours and come back and review them and make sure that pain has returned. And it's important to educate the nurses on the ward that if the patient complains of those things, weakness in their arms or legs, just continuous pins and needles in their arms or legs, or obviously pain, they have to call us. And if these patients need their temperature checked at least 4 to 6 hourly, and if they have a fever above 38 degrees, we need to know about it. It's common for patients to get a fever after surgery, day 1, day 2 from atelectasis. We know that, and that can make things a bit confused. But if we're keeping epidural in for 3 or 4 days and the patient has a fever on day 3 and it's a high fever, we need to know, because whether the epidural being the source of infection, it's unlikely at day 3, but because usually the infection takes about 7 to 10 days to develop. But if they have a sepsis from something, from their chest or infected wound or something like that, the epidural catheter can act as a source for the bacteria to land on. So if they have bacteria in their bloodstream from some other infection, theoretically it can seed to the epidural catheter and spread to the back. So strictly speaking, they say if the temperature is above 38.5, we should pull the epidural out. I must confess that if it's day one and the temperature is 38.5, I'm reluctant to pull out a working epidural. I want to get some chest physio. I want to culture their sputum and make sure they don't have a pneumonia. And if they have a pneumonia and on antibiotics, I would tend to lean on leaving the epidural in for the duration of 3 days. But if they start them on antibiotics, do some physio, and the patient is looking really septic, then I would probably would err on the side of caution and pull it out the next day. And these things are not clear cut. There's no hard and fast rules. Strictly speaking, they would say pull it out. But the number of times you see a fever day one post-op, it's very high. We'd be pulling out half of our epidurals. But I think with epidurals and extrapleural catheters, any regional technique, communication with the surgeon is very important about duration, planned duration, communication to the nurses looking after the patient as well. This is staying in for 3 days. Document it in the patient's notes as well, and put your phone number there so they know who to contact. And following them up is very important. And even if I've done a paravertebral block or a intercostal block, it's still important to follow them up the next day and find out, because you want to know how long your block lasted for, because you want to know if this technique was useful. And you want to make sure they've got some other pain relief written up so that when the block wears off, they don't have to lie in pain all night. You have some morphine or something written up so that when the block wears off, the nurses can have something to give. So all of these things we need to be aware of, especially when we don't have a good pain service in our hospitals. Chest physiotherapy obviously is important with lung surgery. Incentive spirometers, I noticed the guys very good at giving the patients incentive spirometers so far. Both intensive cares I've seen in Palestine, very proactive in that, and that's excellent practice. And ECG is very important. Monitoring after thoracotomy, particularly pneumonectomy. Pneumonectomy patients have a high risk of arrhythmias because often there is a bit of pushing and pulling on the heart, plus we've stressed the right ventricle, and they can get atrial fibrillation. So it's important to have ECG and blood pressure monitoring overnight, ideally for 48 hours. And one thing I didn't mention is a lot of people I worked with used to give magnesium, 2 to 4 grams of magnesium for the pneumonectomy patients, just as an antiarrhythmic. Not really evidence-based, but magnesium just seems to be the flavour of the month for cardiac anaesthetists. They seem to like giving it as a membrane stabiliser to hopefully reduce the risk of arrhythmias. Arrhythmias in the pneumonectomy population can be a bit scary. You know, they stress the heart, and we don't want these patients to get pulmonary edema. These patients are all going to have a chest X-ray post-op, and most of them will get a blood gas because we want to know how they're doing on one lung. They've just had potentially half of their lung function removed, so we need to see how they're doing. And we also need to see how they're doing from a pain point of view. If these patients have a lot of pain, they're going to hyperventilate, their CO2 is going to rise, we need to be attuned to that. So checking their gases will help us. And I think Dr. Hafez has a comment about pain techniques. Hafez, do you want to make a point about NMDA antagonists?
No, just that magnesium is also an NMDA blocker.
Right.
It can't hurt.
Yeah. I think that's a theory. Yeah, it can't hurt. It can cause hypotension if you give it too fast, but apart from that, it generally doesn't hurt. So, post-operative complications. Now, we touched on this previously with the first talk, I think, when I showed you some multiple choice questions, but post-operative complications after pneumonectomy and lung surgery, obviously the obvious ones are going to be respiratory failure from pain and having part of their lung removed. But most commonly, it's the common things, atelectasis. Okay, atelectasis is a complication after any surgery in the lung or abdomen. Arrhythmia, I mentioned, just talked about, particularly after pneumonectomy. bleeding in as high as 3% of cases, and bleeding in these cases has a high mortality, again, because these patients, if they bleed, they can get a lot of fluid, but also they hypertension, tachycardia in the setting of a proarrhythmic operation like pneumonectomy. It can all make a perfect storm. And these patients often have a coexisting ischemic heart disease, and they don't tolerate hypertension and tachycardia. So if the chest drainage is greater than 200 mLs per hour, we need to call our surgical colleagues to come back and have a look at this and possibly go back to the operating room. Cardiac herniation, I mentioned that briefly when we were talking about that multiple choice last week. It's very rare, but it's very dangerous because it causes kinking of the mediastinal vessels, severe hypotension, and is very dangerous. And then there's the problems that we cause with our epidural hypotension, and hypotension can also be from arrhythmias. Infection can occur down the line. They can get pulmonary emboli and surgical problem of an air leak. So air leaks are common because obviously they've cut the lung, but the big one we worry about is a bronchopleural fistula. So that's when they get a very sudden large air leak, and that's very uncommon. But I will talk. I think I have a slide on what we should do if that happens. But it is uncommon. Other things that occur uncommonly are things like phrenic vagus nerve damage, and left recurrent laryngeal nerve can be damaged with a pneumonectomy because it's the one that loops under the aortic arch. So 65% chronic pain. So I said 50. So up to 65 in some studies. So this is, as I mentioned, this is a problem with this patient group. So bronchopleural fistula is, again, something that people like to ask in exams and something that can occur after a pneumonectomy, and it's a very dangerous situation, and it's something that ideally we've all hopefully thought about how we would manage before we have to manage one. But what it is a very large air leak that may be associated with increasing pneumothorax and lung collapse. So if you've had a pneumonectomy, you have a bronchopleural fistula, it's often going to be a breakdown of or some problem with the bronchial stump that they've just sutured. But if it's a lobectomy or something, then you get rapid escape of air where there's still functioning lung tissue, and that will cause a pneumothorax on that size and cause that lung to collapse. So usually first 24 to 78 hours with a pneumonectomy, 24 to 72 hours is early, and that's usually going to be due to a bad surgical closure, or it can be late, like 10 days due to an infection and the suture line gets necrotic. And then there are other uncommon spontaneous causes, such as rupture of a pulmonary abscess into the pleura, pulmonary barotrauma if someone's scuba diving, or indeed if we're ventilating someone too hard, or if the person has a bullous, pleural bleb or something like that, it can be that can rupture as well. It's a very scary situation, and the reason is that if someone's got a really big air leak, imagine a really big hole in a bronchus. If you try and ventilate these patients, if you try and ventilate these patients, all the air is going to go through the air leak. And if they don't have a chest tube, ventilating them will create a tension pneumothorax. And if it's an empyema or an abscess, we don't want to contaminate the lung on the other side. So the aim when managing these is to separate the lungs to control ventilation and prevent cross-contamination if there's infection. And it's a tricky technique. We really want to avoid ventilating these patients, positive pressure ventilation, until we've got lung separation. So I've listed here what I see as the options in getting lung isolation without ventilating the patient. So one way is to do a rapid sequence induction. So there's a few cases in anaesthesia where you really don't want to ventilate the patient before getting your tube in. Okay, tracheoesophageal fistula in a baby is one, diaphragmatic hernia is another, and bronchopleural fistula is another. The reason is that when we positively pressure ventilate, all the air takes the path of least resistance. If you have a very big fistula in your bronchus going out into the pleura, that's going to be the path of least resistance, and then all the air is going to go out there, and the patient's not going to get ventilated, and they'll desaturate. And if you don't fix that situation, they can arrest. So when we're trying to get lung isolation, we need to think of either a spontaneously breathing technique or a rapid sequence induction and with a fast intubation. So one option is using a single lumen tube. You do a rapid sequence induction and do a deliberate endobronchial intubation down the side that does not have the fistula. Ideally, you do this with a fiber optic bronchoscope. So if we've just had a pneumonectomy, it makes life a little bit simpler because obviously there is no lung on that side that has the fistula, assuming that's where the fistula is coming from. So we only need a single lumen tube, and hopefully it's a left-sided pneumonectomy, and the tube will usually want to go down the right, and we could probably not need to use a bronchoscope. So pneumonectomy is a slightly different scenario because we've only got one lung that we need to intubate. But if it's a lobectomy, or if it's a patient with a spontaneous bronchopleural fistula from some of the causes I talked about, then the aim would be rapid sequence induction. Put the tube into the trachea, quickly put the bronchoscope into the tube, and then push the tube down into the side without the fistula, and then you can ventilate that side. The other option is to do a rapid sequence induction with a double lumen tube. The problem with this, it sounds good in theory, and it would be an acceptable exam answer, but in real life, most of us don't put double lumen tubes down every day, and they can be fiddly, and it can take a minute or two to get the tubes in, and to do it in a hurry, if you haven't done many, is very difficult and very stressful. So it can be hard. If it's a right-sided double lumen tube, it's even harder. But that's another option. The other two options are an awake fiber optic intubation. So it's very difficult to do an awake fiber optic intubation with a double lumen tube because you're putting local anaesthetic in, and you're going to intubate the patient with local anaesthetic only, and you've got to railroad the double lumen tube over the bronchoscope, and they're very rigid, stiff tubes, and it can be very hard to do. But you could do it with a single lumen tube, put it into the affected side, and leave it. Or if you're worried about contamination, you could then use a tube exchanger and put in a double lumen tube. And then the fourth option is which is probably what I would do, is do an inhalational induction and intubate while the patient is spontaneously breathing with either a single or a double lumen tube. I think the rapid sequence with an endobronchial intubation is probably, in most people's hands, going to be the best bet. A gas induction and spontaneously breathing, if you are really nervous and the patient's saturations are already 80% or something, then gassing them down with sevoflurane or halothane and keeping them spontaneously breathing, and then spraying the vocal cords and intubating might be a reasonable option. My only concern with this is if they're a frail patient, as you get them enough sevoflurane or halothane on board to intubate them, you might cause a significant drop in their blood pressure. So that's the potential downside I see with that technique. But if I'm really scared, a gas induction I find is one of the safest ways, because then you can, if you're losing, you can always turn the gas off, wake the patient up, and think again. In the case of a bronchopleural fistula, you may not have a lot of time to wake the patient up. But I think all of those options are reasonable options, and at the end of the day, you will do whatever you have the most experience with. I'm a pediatric anaesthetist, so I do gas inductions every day, so I'm very comfortable doing them. If you've never done a gas induction, I wouldn't recommend starting with this. I would recommend then doing a rapid sequence induction, which I'm sure you guys do more often, and do that. But that's a scenario that just talking to you about it, I get nervous because I think it's a very scary scenario. Fortunately, we don't see it very often, but it does come up in exams. People like to ask in exams how you would do that. So that's the thoracic surgery. I have a few other slides on other types of surgeries, but I know it's been a long lecture, so I can stop here. If people are happy, we can stop here and not do those other slides, unless people want me to finish. It's probably about another 20 minutes if we continue. So we can people can vote by just logging out, and then I'll know what the answer is.
I think is the remaining 20 minutes thoracic or
It's thoracic. It's esophagectomy and a mediastinal mass, and yeah.
Well, we've been at this a couple hours. I think we should probably convene at this point and maybe do for the next lecture tomorrow, maybe tomorrow night.
Yeah, I mean, I should be okay.
Tomorrow night and next Friday. How's that?
Yeah, that sounds fine. So we had a request for Sunday night. Do people prefer? So tomorrow is Saturday, isn't it? Do
Sunday,
people prefer?
please. Somebody said Sunday.
Yeah.
I think Sunday has to do with. I think Sunday has to do with the TV show. So I am frankly not going to accept that, Roba. I'm sorry that you can record. It's easier for you to record the TV show, the Arabs Got Talent or something like that. Much easier than it is to worry about the science of anesthesia. So, I
don't mind. Either I'm happy to do tomorrow or Sunday, whatever people prefer.
Okay. She already missed it. Oh well. How about tomorrow night, everyone?
What do people want?
I'm writing.